Hello everybody, welcome back to MBME 27. Today we're covering question 71, that's section 2. These are all unique topics and questions. Here we go. You might see a 52-year-old construction worker who has some swelling and discomfort at the back of his right elbow. He recalls leaning on the concrete floor while working on the tile installation. On exam, there's soft, fluctuant, non-erythematous mass overlying the Olecranon. Range of motion at the elbow is preserved and non-tender, so this is going to be a bursa. This is due to the prolonged pressure on the posterior elbow. The fluctuant, circumscribed swelling without the signs of systemic inflammation will point to that bursal inflammation rather than a joint pathology. So the big things to look out for is that fluctuating nature. It's a fluctuating mass over the olecranon, and that indicates your fluid-filled structure, which is classic for your bursa. And also you can have septic bursitis, and that's in immunocompromised patients where the skin breaks. There you'll see erythema and it'd be warm. Occupational risk would be like plumbers, miners, wrestlers, those with chronic microtraumas. So you get the fluid accumulation in the olecranon bursa that leads to the swelling. If it's infective, you get neutrophils infiltrating there and septic bursitis with erythema and warmth and tenderness. Okay, so why is it not synovial membrane? Well, that's joint inflammation. That would involve pain with motion and also systemic if we're inflamed. So the pain with motion is the reason why that's not the right answer. Tendon sheath, that would be involved with crepitus or pain involved in the muscle activation. And here, the motion is painless. So it can't be the tendon sheath. Ulnar collateral ligament. So that's going to be instability if you have some ligament problems. That's trauma to the medial elbow. No valgus stress mechanism, so that's not the answer. And then hyaline cartilage, that'd be degenerative joint disease or trauma that would affect the joint surfaces. So the elbow has over a dozen bursa, and when one swells up like a big old goose egg, then the thing that's like swelling is probably going to be the problem, right? So it's the olecranon bursitis, shows up after repeated or prolonged trauma and pressure, like leaning on your elbows at work or sports. You'll find a soft fluctuating mass in the back of the elbow and it's painless unless it's infected. All right, so in our next one, we're going to have some sort of like a baby who has a high fever for 3 days that resolves and then you get rash. Okay, so that is Roseola. And the way I want you to think of this is like, hola. That means like suddenly appears a rosy rash. All right, hola, a rash. So that is because there's a fever first and then hola, it's a rash. Roseola. All right, rose, a red, rose, rash, hola, it's there. Pink, blanching, macular rash that starts in the trunk and then it spreads outward. So it's centralized and then it goes outward. So the fever precedes the rash in HHV6, which is what this is. And unlike other herpes virus, there's the latency and CD4 positive T cells. So the HHV6 infects those and contributes to immunosuppression sometimes. So here's a practice question. We have a 9-month-old boy brought to the clinic, sudden appearance of a pink rash 3 days early at a high fever. Boom, that's like enough. I'm just going to go with HHV6. Like it's done. Coxsackie, I drew a couple of these, like Coxsackie's like hand, foot, and mouth. So you'd see hand, foot, mouth disease like vesicles in the palms and the soles and the mouth as well. Rubella, that's a rash that begins on the face and it spreads downwards, rubella. Parvovirus B19, that's the slapped cheek, followed by a lacy trunk rash. It affects the older children, not the infants, so older typically. And streptopyogenes, that's like scarlet fever, sandpaper rash with a strawberry tongue and pharyngitis. So there the rash occurs with the fever, Okay. Roseola, there it is. And you have to remember that's herpes virus 6. Okay, so try to make that as easy as possible, but it's the fever and then the rash, hola, then the rose, and it spreads to the salivary and then the lymphatic system. And you have to know the MMR vaccines are going to cover for your measles, but this is different. This is human herpes virus 6. Okay, so that's 72. Here's 73. All right, so for this question, they're going to give you some version of this, maybe like especially on the hands. Like they always love this type of picture. And then they're going to say there's a 7-year-old girl who presents with a rash that's getting worse. Her mom says the itching is so intense that she cries. There's erythematous papules and linear streaks on the wrists and also the groin, interdigital spaces as well. What's most likely to support this diagnosis? Has anybody in the house had this as well? So this is scabies. It's going to be itchy rash in close contacts. All right, here's the explanation and the answers. But new foods is getting at an allergy. Detergent is getting at contact dermatitis. Animals would be the zoonotic infections, and travel is the parasites and tropical diseases. So relentless nighttime itching. So worse at night. Don't let the bed bugs bite. Scabies. You have the burrows and the web spaces, intensely pruritic papules. And our papules are the small raised solid pimples or swelling. So this is close contact transmission. It can also be a secondary infection with Staph aureus or Streptococcus pyogenes. Look out for it's the antigenic debris from mites or egg feces. It's a delayed type 4 hypersensitivity reaction. Super duper itchy, especially at night, due to the immune cyclicity and the warmth. So you get scratching, which causes those excoriations as well. And there's a risk of superimposed infection like impetigo, just that nighttime scratching. And what you really need to know is the treatment is going to be permethrin or oral ivermectin. Okay, for our next question, they're going to show you a diagram of the circle of Willis. And they're going to say like, hey, what's this guy right here or this guy right here? Like our posterior cerebral artery If this is damage, what would you see? And an example, our practice question is a 68-year-old man with sudden onset difficulty seeing out of the right side of his visual field. He denies weakness or numbness, and he's got a right homonymous hemianopsia. The central vision is intact, and there's an infarct to the left occipital lobe. What's damaged? It's going to be the left posterior cerebral artery, supplies the left occipital lobe, and causes right homonymous hemianopsia. Macular sparing is due to the collateral flow from the MCA. So here's your right hemianopsia. So here's an example where we have a left cerebrovascular event right here, and we follow this red pattern, and this side of the field on both sides is cut off. Our posterior cerebral artery causes that right there. Lesion at 4 causes that right homonymous hemianopia. The width macular sparing would be due to those collaterals right there. Here's another slide on our PCA stroke. Left-sided stroke, right-sided stroke. And here's how they cross over. That's why the left, you'd see the right side, and the right, you'd see the left side, would be cut off. Always in the pathways behind the optic chiasm. All right, so there we go. The answer is D, left PCA causing the right-sided homonymous hemianopia. This would be like aphasia. Left ACA would be a leg weakness. No visual problems there. Right posterior, the pica is Wallenberg syndrome. So you'd have hoarseness, vertigo, and the superior cerebral is cerebral ataxia. All right, our next question is kind of fun. 74, we have a full-term newborn is assessed within minutes of birth. She is breathing spontaneously, pink and vigorous. Which change is most likely occurring in her circulatory system? It's an increased flow from the aorta to the pulmonary artery. So after birth, this wonderful thing, pulmonary vascular resistance drops. And it drops super rapidly due to the lung expansion and oxygen exposure. And so you have a dramatic rise in the pulmonary blood flow. That's critical for the oxygenation of the neonatal blood. Those first breaths, what happens there is it causes alveolar expansion and oxygen-mediated vasodilation, and that lowers your PVR. There's also a reversal of your fetal shunts, and that's important here. Ductus arteriosus and the foramen ovale, these guys close due to pressure changes. Now the blood will just flow to the lungs. Yay! Some associations to know of are PPHN, persistent pulmonary hypertension of the newborn. That's a failure to decrease the PVR. You could also have congenital heart diseases, like right to left shunts, like ductus arteriosus remaining open to bypass the pulmonary circulation. And preterm infants have a higher risk for surfactant deficiencies as well, which then would cause a less of a PVR drop because there's inadequate alveolar inflation. And so in utero, you have high PVR. The blood bypasses the lungs via the foramen ovale and the ductus arteriosus. But then at birth, taking that breath, the lungs expand and the oxygen dilates to the vessels, and then the PVR will just fall really sharply. So you have increased blood flow to the lungs. There's more to return to the left atrium, and so the foramen ovale will then close. And the flow through the ductus arteriosus will reverse and decrease, and then eventually it'll just completely close. All right, for 75, in our next practice question, we have a 42-year-old nurse undergoing tuberculosis screening as a pre-employment testing. She receives a blood test that measures interferon gamma production after exposure to TB. So she's been exposed. Which immune cell primarily is responsible for this test result? The answer is T lymphocyte. So our B lymphocytes, these guys make antibodies, and they're not part of the cell-mediated TB response. They make antibodies. Macrophages, they're present, but they don't secrete the interferon gamma. Now, interferon gamma release after mycobacterial antigen exposure is the hallmark of a T-cell mediated immunity. So you have latent TB testing. That'll directly detect your Th1/CD4 positive T-cell activation. That's what we're testing for if we're doing latent TB tests. It's called an IGRA. It's an interferon gamma release assay. So the pathophysiology is you have a prior TB exposure. So there's TB-specific peptides that are processed and presented via the MHC class 2. So MHC class 2 is like, hey guys, check out this old thing I found. Then the memory CD4 positive T cells recognize that antigen. They activate interferon gamma, stimulates the macrophages, and drives the cell-mediated immunity against the intracellular pathogens like mycobacterium and tuberculosis. And so Th1 CD4 positive T cells are the main producers of interferon gamma in this assay. And so you'll detect the memory, and then the interferon gamma release will cause a positive test so the T cells recognize the TB antigens. And again, our B lymphocytes, these guys, are antibody producers. They're not involved in interferon gamma stuff. Dendritic cells, they present antigen, but they do not secrete interferon gamma. Neutrophils are phagocytic, rapid responses, not going to be specific to the memory of the TB. And mast cells are involved in histamine release, so that wouldn't be the answer either. So yeah, the immune system just remembers the microbe. It's like, hey buddy, I haven't seen you in a while. Basically, it'll say, I've been exposed to you before. The memory T cells, like the CD4 positive Th1 cells specifically, are going to start to release interferon gamma. This is called cell-mediated immunity. So if you see elevated interferon gamma, after you give them this assay, then it means the T cell lymphocytes are doing their job. And so the correct answer is going to be your T lymphocytes. Okay, next we have a 9-year-old boy who was stung by a wasp while playing outside. 10 minutes and he develops intense redness, warmth, and swelling of the site. Which of the following chemical mediators is most directly responsible for the acute findings? Answer is bradykinin. So redness and swelling That means we got acute inflammation, and there's postcapillary venules and vasodilation, because that's the key vascular site of the action of these early mediators. And what are these mediators? Well, typically you think of histamine is going to be there, bradykinin, and also your prostaglandins. Now, what exactly is bradykinin? Well, bradykinin is a super powerful vasopeptide that's generated from kininogen via the kallikrein. And that's during the tissue injury after an allergy exposure. So you think of like a red ant bite or something like that. It'll vasodilate the postcapillary venules and it'll cause redness. That's called rubor, heat. That's called calor, and also increase the vascular permeability. That's edema. So that's called tumor. And it'll sensitize the nerve endings, and that'll cause the pain, which is called dolor, which is how it is in Spanish, actually. And so bradykinin is a fast-acting and super key early inflammatory marker, and that's especially going to be true for things like venom, injury, or allergies. Now, some other answers that they could give you, there are plenty of them. Let's just list a couple of them. We'll start out with like interleukin 1. So interleukin 1, that's a cytokine that's involved in later inflammation. So the triggers for that one would be like fever, adhesion molecules, not rapid vasodilation. So that's more of like a fever thing. They might be able to ask you other things like C3b, and that's an opsinin, which basically means it's like an antibody or some other substance that can bind to a foreign organism or cell, and it'll make it more susceptible to phagocytosis. It helps it get chomped up. Like if you're ever playing like Pac-Man or something, it's like you hit those little things and all the ghosts turn blue and it helps you chop it up. That's like an opsinin. It's not a vasoactive mediator. It helps phagocytosis. It's not vasodilation at all. Other answers they could give you is like thromboxane. So thromboxane A2, that'll promote vasoconstriction and platelet aggregation. So that'll do platelet aggregation, not dilation specifically. And necrosis factor is upregulating adhesion molecules to activate your leukocytes. Doesn't directly dilate. So within minutes after you get injured, the innate response is going to kick off. Mast cells, basophils, endothelial cells, they're all going to release vasodilators. And those are these things that I told you in the beginning. Histamine, prostaglandin E2, bradykinin. That all increases blood flow, and that causes warmth and redness. And then permeability, that will cause the swelling. And bradykinin also makes you feel the pain. Bradykinin makes you hurt. And that's why acute inflammatory response, especially one that involves like a venomous insect bite or something crazy like that, is going to be super important in driving those early signs. So bradykinin, super powerful, dilates the postcapillary venules, increasing permeability, sensitizing the pain. Bring on the pain. In our next practice question, we have a 12-year-old boy who was evaluated for a heart murmur. First heard in early childhood. He has no symptoms. On exam, there's a soft systolic murmur heard at the left upper sternal border and fixed splitting of S2. This is ASD. We can just lock it in there. ECG also says right axis deviation. So let's explain some of these concepts. The fixed splitting of the S2 is classic auscultation clue due to the delayed pulmonary valve closure. There's also the left to right shunt because the blood is moving from the high pressure in the left atrium to the low pressure in the right atrium, shunting on over. And it's asymptomatic until adulthood. So typically they're going to be a little bit older. There's some types that you should know, like the secundum, that's the center of the atrial septum, the fossa valis. That's where it's most commonly placed. There's also the primum. That's near the AV valves, the seen Down syndrome patients. I think there's some information about this up here. Sinus venosus, that's near the SVC. It can be associated with anomalous pulmonary venous return. But the pathophys can typically be pretty constant here. We have normal fetal circulation that uses the foramen ovale to bypass the lungs. So we have that good old foramen. After birth, the left atrial pressure is going to rise and it closes that foramen. And in ASD, the septal tissue fails to close, and so it has a persistent opening. And so the blood will shunt from the left to the right, and you have increased volume in the right atrium. And there's chronic volume overloads. There's pulmonary hypertension, right heart dilation, and eventual Eisenmenger syndrome. That's the reversal of the shunt. You'll see a fixed splitting of the S2, increased pulmonary vascular markings, right atrial and right ventricular enlargement. And a primum ASD is linked with the AV septal defects and Down syndrome. You should know of complications like Eisenmenger syndrome, that's cyanosis, and also clubbing. There's paradoxical embolism. That's when you have a stroke from a DVT that will cross over the circulation, like here's your heart and it'll cross over. And also atrial arrhythmias from chronic atrial dilation, especially like atrial flutter or atrial fibrillation. Now, a bubble study will detect that shunt and you'll see right axis deviation typically. So a small ASD is often, it'll close spontaneously on its own. So yeah, you'll see like a kid, like a 6-year-old boy or something brought to evaluation for a heart murmur, otherwise totally healthy, but there's like a grade 2 out of 6 ejection murmur at the left upper sternal border with the fixed splitting of the S2 sounds. Just lock an atrial septal defect. All right, next we got a statistics question here. A new chest pain risk calculator is being piloted at a sample of 1,000 patients. In this group, we have 580 individuals who have coronary artery disease. What's the pretest probability? Well, it's just going to be super simple. It's that over that, so it's 58%. Not even kidding, that's how easy it is. Okay, ACH agonism. However, if drug Z is given later, it reduces paralysis. Which the following describes drug Z. So early, it causes it, reduces it. So succinylcholine alone will cause muscle paralysis. So our drug that we're giving enhances acetylcholine during phase 1 and it reverses it during phase 2. This has to be some sort of a paradoxical effect, and this is classically seen in cholinesterase inhibitors like neostigmine. So let's talk about the mechanism here. Succinylcholine is a depolarizing neuromuscular blocker. It's a nicotinic acetylcholine receptor agonist. It'll bind to acetylcholine receptors. It causes persistent depolarization and it blocks repolarization. That's what succinylcholine does. Now, this is metabolized. It's broken down by plasma pseudocholinesterase, not acetylcholinesterase. So we use this for a rapid sequence intubation because it's got a super quick onset. So there's the phase 1, right? We got to divide this into phases. Phase 1 is depolarizing. So succinylcholine continually stimulates nicotinic acetylcholine receptors. That'll cause constant depolarization, so the sodium stays inactivated. Muscles can't repolarize, so you get what's called flaccid paralysis. Then cholinesterase inhibitors, like neostigmine, they worsen that block. Why? Because they increase acetylcholine. So more acetylcholine and succinylcholine means prolonged depolarization. But then there's block 2, the phase 2. And at phase 2, the receptors become desensitized. They're like, okay, I've had enough, I get this. Now the receptors don't respond to acetylcholine. And now it'll behave like a non-polarizing block. So neostigmine actually helps because more acetylcholine competes with the acetylcholine that's there, and so the normal function is restored. So it enhances phase 1 by blocking acetylcholinesterase. That increases the acetylcholine and it prolongs depolarization. So you break down the things that break down the thing, which is acetylcholine. And then later on, you reverse the phase 2, the reversal phase 2. The acetylcholine now outcompetes the succinylcholine on desensitized receptors. And they're going to try to throw a bunch of trap answers at you. For instance, botulinum toxin, that inhibits acetylcholine release. And so it's irreversible paralysis. That's not reversible. Dantrolene is used for malignant hyperthermia. Reminds me of the Taylor Swift song, "You Need to Calm Down." Because she says it like that, down. Because you're calming down hyperthermia, malignant hyperthermia. Verapamil, that's a calcium channel blocker. It works on the cardiac smooth muscle, not the neuromuscular junction at all. Pancuronium is a non-depolarizing blocker. It would antagonize, not enhance the depolarizing block. Here we are talking about neostigmine. So it's not dantrolene. They could give you other answers like atropine is always going to be on there. And that can be pretty tempting, but that's a muscarinic antagonist. So it affects the heart, saliva, and the bronchi, not the neuromuscular junction. Rocuronium could be another one, but that's non-depolarizing. It competes with acetylcholine and blocks the receptor. So it'll decrease its effect if it's given together. So basically what you need to know is choline creates a unique two-phased block. Phase 1, neostigmine would worsen it, and phase 2, neostigmine would reverse it. Now, I believe this topic can be pretty confusing, and this is super high yield, so let's break this down even further. We have 2 drugs. 1. So succinylcholine, what it does is it mimics acetylcholine and it binds to the muscarinic receptors. Causes a brief muscle twitch, fasciculations, and then paralysis. So it keeps the receptors on for too long, and so they can't reset, so they stay limp. That's what succinylcholine does. It pretends that it's acetylcholine and it goes and attaches to those receptors. There are 2 stages. There's phase 1 where the muscle is stuck in a turned on state, and neostigmine makes it worse, right? Because you're adding more acetylcholine, so it keeps the receptors even more activated. So neostigmine, the way that I like to say that is it's neo, so you're adding new stigmine, new acetylcholine. So initially it's going to make this stuff worse because this is kind of mimicking acetylcholine, so you add the more acetylcholine, it just makes it absolutely worse. But then the receptors get really tired and they stop responding. It's kind of like a normal muscle block. And so then it'll help reverse it because adding acetylcholine will then outcompete the succinylcholine. And so the receptors get used to it. They're like, okay, it's time to actually do something about this. And then the saliva and the tears and the GI tract, it increases digestion. And so atropine blocks the muscarinic receptors only. It does not even touch the muscles. Atropine has no muscle stuff. Atropine, no neuromuscular junctions. And so we're talking about succinylcholine and acetylcholine. These guys work at the neuromuscular junction. Atropine is not going to work in the neuromuscular junction. Works in the muscarinic receptors. Succinylcholine works in the nicotinic receptors of the neuromuscular junction. So that's just different, right? We're asking about muscle paralysis, so it's the nicotinic, not the muscarinics. So muscarinic, again, is the organs. Nicotinic is the skeletal muscles. Atropine blocks the muscarinic only. Succinylcholine works with the nicotinic only. And so atropine has no effect on the muscle paralysis from succinylcholine. That's the reason why it's the wrong answer, but everybody loves to choose it. Everybody loves choosing atropine. All right, question 80. We have a 62-year-old woman with a history of long-standing rheumatoid arthritis going under knee replacement surgery. Her neck x-ray was not obtained preoperatively. During induction of anesthesia, her head is extended to facilitate endotracheal intubation. Postoperatively, she fails to move her limbs and is areflexic. Which of the following is most likely the cause? Answer, Atlantoaxial subluxation. So this occurs when chronic rheumatoid arthritis erodes the transverse ligament. That causes the instability between the C1 and the C2. So in these questions, somebody's going to have long-standing rheumatoid arthritis. They're going to have suddenness of all limbs after intubation. There's no focal neurological signs beforehand. You just intubate them and then boom, whoop. It's an Atlantoaxial subluxation with spinal cord compression. So rheumatoid arthritis can slowly destroy the cervical spine joints, especially the atlantoaxial joints, the C1, C2, and it makes them unstable. So during intubation, the neck is extended. The spine is unstable, and that motion causes a push on the odontoid process, which is the dens of the C2. And that causes a sudden spinal cord injury, and that causes acute flaccid paralysis. So you have the spinal shock that's early, the flaccid paralysis, areflexia, and then later you have the reflexes that return and spasticity will develop. So patients who have long-standing rheumatoid arthritis are at risk for cervical spine instability, and there's neck extension due to intubation that causes Atlantoaxial that compresses the spinal cord, leading to sudden areflexic paralysis. Here are some trap answers why they're wrong. Epidermal hematoma, that's trauma, coagulopathy, gradual progression, myelinolysis, vertebral artery dissection. That's when you have trauma to posterior circulation stroke, not symmetrical paralysis, and Guillain-Barré is ascending paralysis over days, not sudden quadriplegia, boom, after you've intubated. So most of the time, it's like 80% of patients who have long-standing rheumatoid arthritis will also have cervical spine involvement, and most of them won't even know about it. And one of the most dangerous spots that you should just be aware of is the atlantoaxial joint, because that holds C1 and C2 vertebrae together. And so you neck extend and slip and then crush the spinal cord, and that can cause paralysis. All right, so we're there. We made it to question 80. If this was helpful, then like and subscribe, and we'll see you guys in the next video. Thanks so much for watching.